Creeping on stairs is 15 months. What is child number 2 doing? He's standing holding on to a support. So this can be done at the age of 9 months. So this child is 9 months. Picture number 3, he's sitting without any support. So he's not taking a support, he's sitting without any support. So this is a child who should be somewhere around 8 months. Sitting without support, somewhere around 8 months. Picture number 4, what is this child doing? He's enjoying a peekaboo game. So peekaboo game, 10 to 12 months. Picture number 5, so this is an ulnar grasp. Ulnar grasp, 6 to 7 months. Remember, ulnar grasp 6 to 7 months, radial grasp 8 to 9 months, pincer grasp 9 months, and a mature pincer grasp 12 months. Picture number 6, the child is creeping, but now he's creeping on stairs. So remember, creeping at 10 months, but creeping on stairs 15 months. So this is a child who is 15 months. This is a child who is 10 to 12 months. And this is a child who is 6 to 7 months. And what is this picture number 7? This is a child who is mouthing, bringing things to his mouth. So this is a child who should be around 5 months. Right? Picture number 8. So this is a child who is throwing away the things. So this is casting. He's throwing away the things. So this is a child who should be 12 months, casting at the age of 12 months. And this is a child who's standing in front of a mirror, enjoying his mirror image. So this is a child who should be, when does a child plays with his mirror image? Somewhere around 6 months. So this is a child who's around 6 months. So this is how, when questions will be given to you in the exams, this is how you will answer based upon what milestone the child in the picture appears to be performing. So again and again I'm saying, thoroughly revise these milestones, and whenever you get the time, please go through these milestones. That's the only way to remember the milestones for your exam. Okay, so just before we finally take a break, because after this we'll start with neonatology. So just one last slide that I would like to tell you, just 5 more minutes before we take a break. These are some important points which I feel are important from your examination point of view for breast milk. So please see this one by one. Breast milk is the most important milk which is responsible or which is contributing to the survival of a young infant. Breast milk has plenty of anti-infective factors, and the most important immunoglobulin that is very high in colostrum in breast milk is IgA. Right? So breast milk has very high concentration of which immunoglobulin? It is IgA. Both breast milk and colostrum. I hope you all know this. If you do not, I'll just tell you, colostrum is the first milk of the child. Colostrum is the first milk that the child receives, and the first 3 to 4 days breast milk that the child receives is known as colostrum. Then transitional milk is the milk which the child drinks from around 4 days to 14 days. And mature milk, mature breast milk, is the milk which the child receives after 2 weeks. So the milk that the child receives in the first 3 to 4 days is the colostrum. Yellowish color, thick, highly rich in secretory IgA. The milk from the 4th day till the 14th day that the child receives from the mother, that is known as the transitional milk. There are certain changes that go on from colostrum to the final constitution of the mature milk. This mature milk is the milk that the child receives after 2 weeks. It has very good amount of carbohydrates, which are around 7 grams per deciliter. A very good amount of carbohydrates. And the main carbohydrate that is present in breast milk is lactose. Then there is also some proteins present, although the protein concentration of the breast milk is only about 1 gram per deciliter. This is a very, very important difference between breast milk and cow's milk. Cow's milk protein content is very high, but thankfully the protein content in the breast milk is very, very low, because the condition of the kidneys in a newborn is very, very immature. Newborn kidneys are very immature. They will not be able to handle the high protein load which is present in cow's milk. Therefore, Human milk, breast milk has very low amount of protein, which is just about 1 grams per deciliter. And the main protein which is present in the breast milk is the whey protein. Which is the main protein which is present in the breast milk? Whey proteins. Just remember it like this: whey and women. So women's breast milk, WW. Whey protein is the main protein which is present in the breast milk. This is in comparison to the protein that is present in cow's milk. The cow's milk protein is casein. The main protein which is present in cow's milk is casein. Just remember, cow C, casein C. Women W, whey protein W. So which is the main protein which is present in breast milk? It is whey protein. And which is the main protein which is present in cow's milk? It is casein. And how much are the fats which are present in breast milk? So fats are around 4 grams per deciliter. So I'll again repeat: 7 grams per deciliter of carbohydrates, 1 gram per deciliter of proteins, and 4 grams per deciliter of fats in breast milk. And this is the milk that usually the child receives after 2 weeks. So it is also known as the mature breast milk. Colostrum, first 3 to 4 days, transitional milk from 4 days to 14 days, and the mature milk is after 14 days, after 2 weeks. The main protein that is present in cow's milk is casein, but the main protein that is present in breast milk is the whey protein. I hope you have all written this. Okay. Let us come back to our slide. So, the mature milk has which amount of immunoglobulin which are very high? It is IgA. Then the second important thing to remember is that milk contains good concentration of many vitamins also, but the 2 vitamins which are usually low in breast milk are vitamin K definitely and vitamin D to some extent. Especially vitamin D deficiencies in mothers who actually are themselves vitamin D deficient. So when vitamin D deficient mothers are there, their breast milk will contain less amount of vitamin D, and these children are likely to develop vitamin D. So this is a wrong fact that India, being a sun-drenched country, we all contain very good concentration of vitamin D. No. In fact, Indian Academy of Pediatrics recommends vitamin D supplements should be started in children after the end of infancy, or usually after the exclusive breastfeeding has ended. The reason being very simple, that vitamin D deficiency is present, especially if the child is receiving breast milk from a mother who herself is vitamin D deficient. And vitamin K obviously deficiency is there, so vitamin K 1 milligram intramuscular should be given to all term newborns, and 0.5 milligrams intramuscular should be given to all preterm infants whenever the child is born. So whenever the child is born, these children should receive 1 milligram intramuscular injection of vitamin K if the child is a term child, and 0.5 milligram intramuscular injection if the child is a preterm child, because vitamin K is deficient in breast milk. You may go through the vitamin D supplementation recommendations of Indian Academy of Pediatrics also, but please remember, vitamin D is likely to be deficient in any newborn, especially if the child is receiving breast milk of a mother who herself is vitamin D deficient. Next, can breast milk be stored? So express breast milk can be stored, but express breast milk can be stored at room temperature for 8 hours, and express breast milk can be stored in a refrigerator for 24 hours. So for how long can express breast milk be stored at room temperature? So if you have expressed the breast milk and you want to give it to a child, keeping it at room temperature. In ghai it is written it can be stored for 6 to 8 hours. So approximately max 8 hours breast milk which has been expressed can be stored at room temperature, and this expressed breast milk can be stored in a refrigerator for up to 24 hours. In deep freezers it can be stored even longer, for 3 months. But for your exams I think it is only sufficient to know at room temperature it can be stored for 8 hours, and in a refrigerator it can be stored for 24 hours. Both of them are important questions, especially PG entrance, both of them have been asked. Then I've already told you what are the contents of breast milk. So breast milk contains how much of carbohydrates? I told you 7 grams per deciliter of carbohydrates. And how much of protein? 1 gram per deciliter of protein. So which is the main carbohydrate in the breast milk? I told you it is lactose. And which is the main protein in breast milk? I told you it is whey proteins. So compared to cow's milk, higher content of carbohydrate and lower content of protein. So breast milk contains higher content of carbohydrate compared to cow's milk and lower content of protein compared to cow's milk. Fats in breast milk and cow's milk are almost equal, right? So there should be no confusion in breast milk and in cow's milk. So in breast milk, carbohydrate is more, less in cow's milk. Proteins, in breast milk it is less, in cow's milk it is more. And fats almost are comparable in breast milk and cow's milk. The last thing that I would like to tell you are the signs of good attachment to the breast. So there are certain signs that the child has been attached to the breast correctly, because many first time mothers especially are not able to attach the child to the breast properly. Therefore, the child will take insufficient amount of breast milk. So what are the 4 important signs of good attachment to the breast? The first sign, the baby's mouth should be wide open. The second sign, the upper areola should be more visible. Again and again, please remember this question has been asked in the exam. Which of these is not one of the signs of good attachment of a child to the breast? Not one of the signs. And one of the options is lower areola is more visible. No, please remember, upper areola is more visible is a sign of good attachment. Lower areola more visible is not a sign of good attachment. So upper areola should be more visible. Then third, the baby's lower lip should be everted and the child's chin should be resting on the mother's breast. So what are the 4 signs of good attachment of the child to the breast? The baby's mouth should be wide open. The upper areola should be more visible compared to the lower areola. The baby's lower lip should be everted and the baby's chin should be resting on the mother's breast. These are the signs which are given by the UNICEF. So these are the 4 signs of good attachment. Please learn these 4 signs by heart, because they will ask you in the exams 4 signs and they will ask you which of them is not a sign of good attachment of the child to the breast. So first sign, baby's mouth wide open. Second sign, upper areola of the breast. You know what is the areola? The darkened area surrounding the nipple. So upper areola should be more visible compared to the lower areola. The baby's lower lip should be everted and the baby's chin should be resting on the mother's breast. So with this, we finish up the first chapter, which is growth and development. And there are just certain points that I would like to tell you. Rather, I would just feel that go through these points. I don't think it is important to write down these points again, because everything is there which I've already given in the notes. It's only just to remember some important points for exams. So the first sign of puberty in girls, I told you, is thelarchy, and the last sign of puberty in girls is menarche. The first sign of puberty in boys is increase in the size of the testis, and the last sign of puberty in boys is the growth of the beard and sperma. Remember, I told you the signs of puberty in girls and the signs of puberty in boys. So what is the first sign of puberty in girls? It is thelarchy, breast development. Last sign of puberty in girls is menarche. First sign of puberty in boys is increase in the size of the testis, and the last sign of puberty in boys is the growth of the beard and sperma. Mid-arm circumference is used for growth assessment between 1 to 5 years. And as I told you, the definition of severe acute malnutrition. What is SAM's severe acute malnutrition? I told you, any child who is between 6 to 59 months of age. Any child who is between 6 to 59 months of age with one of these three criteria: mid-arm circumference less than 11.5 centimeters, bilateral pitting edema, weight for height less than 3 scores. Any of these present in a child between 6 to 59 months of age, we say the child has a severe acute malnutrition. Then the upper segment becomes equal to the lower segment at the age of 7 to 10 years, while the head circumference becomes equal to the chest circumference between 9 months to 1 year. So which is bigger? Head circumference bigger than the chest circumference. Among upper segment and lower segment, upper segment is bigger than the lower segment at birth. So when does the upper segment becomes equal to the lower segment? Between 7 to 10 years. When does the head circumference becomes equal to chest circumference? 9 months to 1 year. Most common type of short stature is the constitutional delay. But I told you, most common type of pathological short stature is a malnutrition. So most common type of short stature overall is a constitutional delay, but the most common type of pathological short stature is malnutrition. Normal variant short stature or physiological short statues and puberty is on time, familial short stature, but a normal variant short stature where puberties are delayed is a constitutional delay. Then some important milestones: sitting with support is at 5 months, but sitting in a tripod position is at 6 months. Sitting without support is at 8 months, remember. Standing with support is at 9 months, walking with support is at 12 months, sentences is at 2 years, and stories at 4 years. These are the questions that have been asked in the exams. Everything has been told to you in the notes, has been given to you in the notes. And finally, social smile at 6 to 8 weeks. Right? So I hope this lecture was good. The first chapter was good. You have understood the first chapter thoroughly. There should not be any confusion left. At the end of the class, you can ask me the questions if you want to ask. But right now, we'll quickly slip into a break. Before that, I will quickly like to go through quickly, and then we'll take a small break. I started the growth and development chapter by telling you about growth and development. I told you growth is simply an increase in size. Development, I told you, is milestones. Then I told you that growth always progresses in a cephalopodal fashion, from head to toes. Then first 28 days, the child is called as a neonate. First year, the child is called as an infant. 1 to 3 years, the child is called as a toddler. And 3 to 6 years, the child is in the preschool age group. 6 to 12 years, the child is in the school age group. And 10 to 19 years. So what is the WHO definition of adolescent age group? It is 10 to 19 years of age. So 10 to 19 years is the adolescent age group. What's the difference between adolescence and puberty? Puberty is the development of secondary sexual characters. In which age group? In the adolescent period. Then I told you, all these secondary sexual characters develop in a sequence in boys and girls. So first sign of puberty in girls, thelarchy, breast development. Last sign of puberty in girls, menarche, menstrual cycles. First sign of puberty in boys, increase in the size of the testis. And last sign of puberty in boys is the growth of beard or sperma. Remember? Then I told you how do we assess the growth? Age-dependent markers, age-independent markers. The 3 age-dependent markers: weight, height, head circumference. And the 2 age-independent markers: skin fold thickness, mid-arm circumference. Which is the instrument which is used to measure the skin fold thickness? Herpendon's calipers. But which are the instruments used to measure mid-arm circumference? The Bangle test, I told you, 4 centimeter diameter, and the Acute tape. Out of the 5 growth assessment markers, weight, height, head circumference, mid-arm circumference, skin fold thickness, which is the most commonly used? It is weight, which is the most commonly used growth assessment marker. Then I told you 3 methods to calculate the weight if you know the age of the child. So 3 to 12 months, if the child's age is between 3 to 12 months, weight can be calculated by the formula age in months plus 9 upon 2 kgs. If the child is between 1 to 6 years, weight can be calculated by the formula age in years into 2 plus 8 kgs. If the child is between 6 to 12 years, the formula is age in years into 7 minus 5 upon 2 kgs. So if I give you the age of the child, you can calculate the weight of any child. Also, I told you the child's weight becomes double the birth weight at 5 months, 3 times the birth weight at 1 year, 4 times the birth weight at 2 years, 5 times the birth weight at 3 years, 6 times the birth weight at 5 years, 7 times the birth weight at 7 years, and 10 times the birth weight at 10 years. Second, length. Length is calculated till the age of 2 years, standing height after the age of 2 years. What is the length of a child at birth? 50 centimeters. How much length increases in the first year? 25 centimeters. So what is the length of a 1-year-old child? 75 centimeters. But in the case of head circumference, what is the head circumference at birth? 35 centimeter. And how much head circumference increases in the first year? Remember, 12 centimeter. So increase in length in the first year of life is 50% of the length at birth, but increase in head circumference in the first year is 33% of the head circumference at birth. Out of the head and chest circumference, which is more in a child at birth, it is head circumference. The difference between head and chest circumference is about 3 centimeters. When does the head circumference becomes equal to chest circumference? By about 9 months to 12 months. When does the upper segment becomes equal to the lower segment? Between 7 to 10 years. Remember, what is the upper segment to lower segment ratio at birth? 1.7. It becomes 1.5 at 2 years, 1.3 at 3 years, 1.1 at 6 years, and becomes 1. That means upper segment becomes equal to lower segment between 7 to 10 years. Okay. Then severe acute malnutrition. The definition I told you, according to WHO, any child who is between 6 to 59 months of age who has one of these 3 criteria. Which criteria? The child has bilateral pitting edema in the legs, the child has a weight for height less than 3 Z scores, and the child is having mid-arm circumference less than 11.5. Any of these 3 in a child less than between 6 to 59 months of age, mid-arm circumference less than 11.5 centimeters, weight for height less than 3 Z scores, and bilateral pitting edema, the child will be called as a case of severe acute malnutrition. Can be managed in OPD basis, can be managed in hospitals. Hospitalization criteria, I've already told you. First criteria, failure of appetite. Second criteria, severe edema. Third criteria is complications of malnutrition, and fourth criteria are the danger signs. Then I also told you about short stages. So how do you divide short stages? Physiological short stitches, pathological short stitches. Physiological short stitches, familial short stitcher, constitutional delay. Which type of physiological short stitcher? The final height is normal, constitutional delay. That is why we call it as delay, not short stitcher. Which type of physiological short stitcher? Final height is short, familial short stitcher. Which type of physiological short stitches? The puberties appear on time, familial short stitcher. Which type of physiological short stitcher? The puberties are delayed, constitutional delay. Pathological short stature, on the other hand, again divided up into 2, disproportionate, proportionate. How will you find out disproportionate or proportionate? Upper segment to lower segment ratio. So if the upper segment to lower segment ratio is matching for that age, this is proportionate. Not matching, disproportionate. Why is upper segment to lower segment ratio not matching? It is more than expected, infantile disproportion. Less than expected, advanced disproportion. Examples of infantile disproportion, achondroplasia and congenital hypothyroidism. Examples of advanced disproportion, spondyloepiphyseal dysplasia. And what are the examples of proportionate short stitches? Endocrinal, chromosomal disorders, malnutrition, and systemic disease. Then I did about milestones, which were gross motor, fine motor, language, social. I have again saying, nothing for me to teach in the milestones. You have to remember those milestones by heart. Different milestones given in different books, you might get confused. I cannot cater to all the milestones. We have tried to take most of the milestones from guide and authentic books, so just remember the notes. And finally, few things about breast milk. How long can breast milk be stored at room temperature? Express breast milk 8 hours, in a refrigerator 24 hours. What is colostrum? First 3 to 4 days milk that comes is colostrum. 4 days to 14 days milk that comes is the transitional milk, and after 14 days is the mature milk. The mature breast milk carbohydrates are higher than the cow's milk, about 7 grams per deciliter, mainly lactose. Proteins are less than that of cow's milk, 1 gram per deciliter. Main protein, whey. Women, W, whey protein, W. Cows, C, cows, casein, C. And fats are almost equal in breast milk and cow's milk. And then I told you 4 important signs of good attachment of the child to the breast. One of the most important among them. So child's mouth should be wide open, lower lip should be everted, the chin should be resting on the mother's breast, and the upper areola should be more visible, not the lower areola. Right? So thank you very much. I hope you have enjoyed the first chapter. You have understood the first chapter. We'll take around a 15-20 minutes break. And after the break, we'll start with the second chapter, which is neonatology. Right? Thank you.